Okay. So hello everyone. So welcome to the DAMS MDS Predictor series. I am Dr. Rahul Nikumbhe. Today we are going to discuss important MCQs in medicine which are having very high probability to be asked in your exam. So please focus and you have to answer these MCQs. Okay. So let us start with our first MCQ. All of the following are features of mitral stenosis except A. Opening snap. B. Mid-diastolic murmur. Loud S1, loud S2. Yes. So, what is your answer? Mitral stenosis. So, what is happening in mitral stenosis? Mitral wall. It is present between left atrium and left ventricle. There is difficulty in opening of the wall. So, what happens? This stenos wall. When there is obstruction to the flow of blood, to the forward flow of blood from left atrium to left ventricle, what will happen? This mitral wall, it is not opening properly. So, pressure in the left atrium, it will increase. Blood will accumulate in the left atrium, and after that this wall, it will go like this. So wall will go like this. It will produce a sound called as opening snap. After that it will open. And a small amount of blood will go down. When the blood is going through a stenos pathway, a narrow pathway, it will produce a sound. It is mid diastolic murmur. So opening snap, then blood is traveling, then mid diastolic murmur. Then loud S1, it is the feature of mitral stenosis. Loud S1. Why loud S1? When left atrium contracts, large amount of blood will go down, wall will go away. Okay, but it is the stenos wall. So left ventricle is not completely filled. In a normal person, what happens? Blood completely fills the left ventricle. When blood completely fills left ventricle, blood comes below the flaps of the wall, and these flaps, they will come closer. And when the time of closure comes, these cups, they will close from the very near distance. That's why our normal sound S1, it is not loud. In mitral stenosis, when left atrium contracts, these cups, they will go far away. Left ventricle, it is not completely filled, it is half filled. So blood is not coming below the cups. So these cups, they are not coming near. So these cups, they will close from the very large distance. It will produce a loud sound, which is loud S1. Loud S2, it is not the feature of mitral stenosis. Loud S2, it is the feature of systemic hypertension, pulmonary hypertension. Okay, so answer is very good. Alia, Nikesh, Monirudya, Bhavana, excellent, very good. You are correct answer. Next one. Question number 2. What is your answer for this? A 25-year-old lady presents with palpitations, substernal chest pain poorly related to exertion, and finds mid-systolic click on auscultation. Which is the investigation to be done? Which investigation should be done? Most important hint, mid-systolic click. So tell me, what is your answer? Question number 2. What is your answer for this? Yes, Bhavna, Nikesh, Alia. Palpitations, chest pain, but it is not related or poorly related to exertion. So it is giving you a hint. It is not a MI. In angina or in MI, on exertion, chest pain increases. So it is not the MI. Okay. Excellent, Nikesh. Very good. Echo. So you will go with 2D echocardiography. What is your diagnosis? Can you tell me diagnosis? What is the cause of mid-systolic click? What is the cause of mid-systolic click? Mitral wall prolapse. Mitral wall prolapse, it is the cause of mid-systolic click. Okay, so it is the case of mitral wall prolapse. Next, so we will do echocardiography. These symptoms, they are suggestive of mitral wall prolapse. Remember, mid-systolic click, it is the feature of mitral wall prolapse MCQ. Okay, next, which of the following hormone hypersecretion leads to the condition shown in the figure? So first tell me, what is the abnormal feature. Can you tell me which feature is shown in the figure? Yes. Akansha. SAG. Yes, what is your doubt about SAG, Akansha? It is serum ascitic albumin gradient. Serum ascitic albumin gradient. So we will measure the albumin level in serum and albumin level in the ascites. Okay. Then what is the formula of SAG? Serum albumin minus ascitic albumin. This difference, it is SAG. Okay. Now, yes, very good. Excellent. You are correct. Which of the following hormone hypersecretion? It is growth hormone hypersecretion. What is the feature? Prognathism. Clinical feature is prognathism. Growth hormone increases the size of mandible. So there is enlargement of the mandible, size of the jaw increases, lower jaw comes forward. It is called as prognathism. It is called as prognathism. It is the feature of acromegaly. Okay. Next. Which of the following laboratory findings is most consistent with SIADH? Yes. What is the correct answer? SIADH full form? Syndrome of inappropriate ADH secretion. SIADH, syndrome of inappropriate antidiuretic hormone secretion, SIADH. Which of the following laboratory findings is most consistent with SIADH? Yes, Vivek, very good, correct. So remember I for inappropriate. To remember this syndrome, I for increase. Remember this syndrome, remember I for increase. It is the syndrome of increase ADH. It is the syndrome of increase ADH. What is the normal action of ADH? Full form of ADH, antidiuretic hormone. Action of ADH, when ADH is released, it is released from the pituitary. It will act on V2 receptors. V2 receptors, they are present on distal part of nephron, distal tubules, collecting ducts, distal convoluted tubules. So distal part of the nephron, it is having V2 receptors. When ADH acts on V2 receptors of distal part, then what will happen? It will reabsorb water molecules. So lot of water molecules, they are absorbed from the tubules. Water molecules, reabsorption. So water molecules are absorbed, and these water molecules, they are absorbed from the serum, and these water molecules, they are added to urine. No, these water molecules, they are absorbed from the tubules of the kidney. It means water molecules, they are absorbed from the urine. Water molecules, they are added to serum. So now water molecules, they are traveling from urine to serum. So water is added to serum. Serum will get diluted. If serum gets diluted, serum osmolarity will decrease. Water molecules are removed from the urine. Urine will become concentrated. So urine osmolarity will increase. Clear? So patient will have low serum osmolarity, high urine osmolarity. Correct? Very good. So answer is A, SIADH. Okay. Now second question they can ask you, what will happen if there is a deficiency of ADH? If there is a case of central diabetes insipidus, nephrogenic diabetes insipidus. So if ADH is not secreted, or ADH is secreted but it is not able to act on the kidney, in both patients what will happen? Kidneys are not able to reabsorb the water. If kidneys are not able to reabsorb the water, water molecules from serum, they will go towards the kidney. Kidneys are not able to reabsorb the water, so there will be loss of water molecules from serum to urine. So now there will be opposite flow of water molecules. So what will happen? Urine will become diluted, serum will become concentrated. So opposite of SIADH is diabetes insipidus. Increased secretion of ADH, SIADH. Deficiency of ADH or resistant to ADH, it is diabetes insipidus. Okay. Next. What is the expected change in urine output after desmopressin in central diabetes insipidus? Very simple MCQ on the basis of the same concept of ADH. Central diabetes insipidus. Yes. Is it okay now? Central diabetes insipidus. In central diabetes insipidus, there is defect in pituitary. What is the defect in pituitary? Pituitary is not able to secrete ADH, or pituitary is not having ADH. So level of ADH will decrease. There will decrease secretion of ADH. When ADH level decreases, V2 receptors are not stimulated, kidneys are not able to reabsorb the water. So whatever water molecules they are traveling from serum to urine, they are not absorbed, they will be lost in urine. So water is removed from the serum, water is added to urine. So urine will get diluted. So urine osmolarity, it will decrease. Urine output will increase. It is the central diabetes insipidus. Now I am giving the drug desmopressin. Desmopressin, it is the drug. It acts as a ADH. Desmopressin acts as a ADH. Now this desmopressin, it will replace ADH. It will stimulate V2 receptor, and now kidneys, they are able to reabsorb the water molecules are shifted to serum. So now urine output will decrease, urine osmolarity will increase. So decrease in urine volume, increase in urine osmolarity, it is the feature of desmopressin given in central diabetes insipidus. Very good, Alia, Nikesh, Arshia, excellent, you are correct. Next. So next MCQ, patient is having dance like non-pattern movements as shown in the figure. Okay, so you have to tell me where is the lesion. So can you tell me where is the lesion? Dance like non-pattern movements. Where is the lesion? Is it in substantia nigra? Is it in frontal lobe? In subthalamic nucleus or caudate nucleus? Question number 6. Nikki, Alia saying B. Frontal lobe. Arshia saying B. Akansha, Korea, substantia nigra. Okay, excellent. So Nikesh, Moniruddha, you are correct. Correct answer is caudate nucleus. So dance like non-pattern movements involving proximal as well as distal joints. They are attractive movements. They are semi-purposeful movements. These are the features of chorea. So it is a case of chorea, dance like movement. It is chorea. Okay, remember C for chorea, C for caudate nucleus. Lesion in caudate nucleus, it causes chorea. Then you should know about substantia nigra. If there is lesion in substantia nigra, substantia nigra, it is having dopaminergic neurons, the neurons which secrete dopamine. So if there is damage to substantia nigra, there will be deficiency of dopamine. So what is the name of disease? If there is lesion in substantia nigra, if there is damage to substantia nigra, there will be Parkinson's disease, Parkinsonism. MCQ. So they can ask to direct MCQ. Parkinson's disease, it is because of the lesion in, because of the damage to. Very good, Nikesh. Next, if there is damage to frontal lobe is important for our social behavior, for our eye field, horizontal movement of our eyes, then our personality. Okay, then our Broca's area, it is in the frontal lobe. If there is damage to frontal lobe, patient will have neuropsychiatric feature, abnormal behavior, personality disorder, antisocial behavior, Broca's aphasia, then horizontal gaze palsy. These are the features of frontal lobe lesion. Then if there is a lesion in subthalamic nucleus, there will be hemibalismus. If there is lesion in the left subthalamic nucleus, there will be right hemibalismus. What is hemibalismus? Exaggerated chorea, very exaggerated movement of the upper limb, violent movement involving proximal joints more than the distal joints. Okay, it is the lesion in subthalamic nucleus. All these are important MCQs for your exam. Okay, so definition of chorea: rapid, semi-purposeful, graceful, dance-like, non-pattern, involuntary movements involving both distal and proximal muscles. Next, which of the following is correctly matched regarding hyperkinetic movement disorders? Okay, which of the following is correctly matched? So just tell me WXYZ, which one is true, which one is false. W is true, X is true or false, Y is true or false, Z is true or false. So first tell me which sentence is true, which sentence is false. Chorea is due to the lesion in caudate nucleus. Yes, just we have discussed chorea is due to the lesion in caudate nucleus. True. Next, hemibalismus is due to the lesion in subthalamic nucleus. True or false? Yes, it is also true. Just we have discussed. Dystonia. Dystonia is due to the lesion in putamen. Yes, true or false? So we are here. Option A, true, true. Option this is not there. So it is either A or D. But first we have to decide the sentences true or false. See. Next. Dystonia is due to lesion in putamen. It is wrong. It is false. Dystonia is because of the defect in DYT gene. So it is false. Next, athetosis is due to the lesion in globus pallidus. True. Remember the mnemonic gap. Gap. G for globus, P for pallidus, A for athetosis. Lesion in globus pallidus causes athetosis. Okay, so answer is A. So answer is A. Next, cluster headache is characterized by all except. Yes, what is your answer? Cluster headache is characterized by all except. Please focus on the except. Dear students, in exam always you have to focus on the word except. It will change the answer. Cluster headache is characterized by all except. What is your answer for this? Affects predominantly females. First is false. Cluster headache, it is more common in male. Please remember these. All headaches, all primary headaches, most common is tension type headache, migraine. These are common in females. These are common in females. But cluster headache, it is the headache which is common in male. Which is common in male. Monirudya, Nikesh, I told you, you have to focus on accept word, accept. Okay. Oh, so now you got the correct answer. Answer is A. A sentence is false. Unilateral headache, yes. Cluster headache, it causes unilateral headache. It is generally seen in young males associated with conjunctival congestion, or it is also called as redness. What are the characteristic features of cluster headache? Young male coming to you with severe headache only on the one side. Okay, it is associated with conjunctival redness, also called as conjunctival congestion, then lacrimation on the same side, then congestion of the nose on the same side, then alcohol, it is the trigger factor. So young male patient having history of alcohol intake and coming to you with severe unilateral headache with autonomic feature, diagnosis cluster headache. Okay, very good. Next. Okay, very important. Which of the following is correct diagnosis for given serology? Which of the following is correct diagnosis for given serology? So, hepatitis C, HCV RNA positive. HCV RNA positive, it means infection is present. Then IgM anti-HCV negative and IgG anti-HCV, it is also negative. Now give me the correct answer. Hepatitis C, HCV RNA positive, IgM, IgG antibodies both are negative. What is your correct diagnosis? Yes, Anuprabha. क्या बोलोगे? क्या लगता है आपको? IgM भी नहीं है, IgG भी नहीं है, सिर्फ HCV RNA है. HCV RNA है मतलब वायरस तो है. तो क्या बोलोगे? एक्यूट वायरल हेपेटाइटिस, क्रोनिक वायरल हेपेटाइटिस, रिमोट रिकवर्ड इन्फेक्शन ऑफ हेपेटाइटिस सी, और इज इट इंक्यूबेशन पीरियड? यस अनु. Bhavna is saying 9A. Moniruddha is saying D. Now see, remote recovered infection of hepatitis C. If it is recovery, then HCV RNA will be absent. It will become absent. If HCV RNA present, it means virus is present. If virus is present, you cannot say recovery. It is recovery 100% wrong answer. So it is not recovery. Okay, what will happen in recovery? Virus entered, then antibodies are produced. Antibodies kill the virus. So HCV RNA is absent and IgG anti-HCV present, HCV RNA IgM absent. Then you will say it is recovery. रिकवरी कब बोलोगे आप? जब वायरस नहीं होगा, मतलब HCV RNA नहीं होगा. ओके. एक्यूट वायरल हेपेटाइटिस कब बोलोगे? इफ HCV RNA present means virus present and IgM anti-HCV antibody present. Virus present, IgM antibody is telling you duration of virus is less than 6 months, then it is acute viral hepatitis. Chronic viral hepatitis, HCV RNA present and duration of virus IgG anti-HCV antibody positive. So if hepatitis C virus HCV RNA present with IgG anti-HCV antibody, then it is chronic viral hepatitis. If only HCV RNA is there, antibodies are not produced, most of the time these patients are asymptomatic. So virus is present and symptoms are absent. So the time from which a virus entered in the body but symptoms are not produced, or the time from the entry of virus to the first symptom, it is called as incubation period. So this patient, he is in the incubation period. Very good. This patient, it is in incubation period. Next. Next one. Which of the following is typically decrease in Wilson's disease? very simple and very important. विल्सन डिसीज में क्या कम होता है, क्या बढ़ता है सबको पता है, ये पूछ रहे क्या कम होता है। विच ऑफ द फॉलोइंग इज टिपिकली डिक्रीज इन एमसीक्यू एग्जाम। ऑलवेज रीड केयरफुली, क्या पूछा है अच्छे से देखना है आपको, इंक्रीज पूछा है, डिक्रीज पूछा है, नॉर्मल पूछा है। ओके, सो करेक्ट आंसर, व्हाट इज द करेक्ट आंसर। विल्सन में क्या कम होता है, अनुप्रभा व्हाट इज योर आंसर। Excellent. Very good, Alia. Arshia, Nikesh, excellent. All of you are correct. The answer is serum ceruloplasmin. Serum ceruloplasmin. So what happens in Wilson's disease? Normally, in a normal person, suppose this is liver, okay? Then, suppose this is hepatocyte. So this is, suppose, hepatocyte, okay? In a normal person, what happens? Free copper combines with apoceruloplasmin. Free copper combines with apoceruloplasmin to form ceruloplasmin, and now this ceruloplasmin it is transported to the blood. This ceruloplasmin it is transported to the blood, and this ceruloplasmin it is the main form of copper which is present in blood. It is the main form of copper. So if I say serum total copper, if I say serum total copper is 100%, then this total more than 96% of total copper it is in the form of ceruloplasmin, and less than 4% it is in the form of serum free copper. Okay, so less than 4% is serum free copper. Now what happens in Wilson's disease? In Wilson's disease, in liver, free copper is not able to combine with apoceruloplasmin. There is defect in ATP7B gene. Free copper is not able to combine with apoceruloplasmin. So ceruloplasmin level decreases. Ceruloplasmin level decreases. This free copper is not able to combine with apoceruloplasmin, so free copper will increase. Now this free copper it will increase in blood. So serum free copper increases, it will go towards kidney. Kidney will try to excrete the copper. Serum copper, urine copper will increase. Liver copper it will also increase. Okay. So this is your answer. Next MCQ on the same topic. Remember, serum total copper also decreases. Serum total copper decreases because ceruloplasmin severely decreases. This free copper it will get deposited in the liver. When liver gets saturated, then this free copper will enter into the blood. So this increase in free copper it is not in the same proportion of decrease of ceruloplasmin, because most of the free copper is stored in the hepatocyte. Okay, so this is your MCQ. Serum ceruloplasmin decreases, serum total copper decreases, serum free copper increases, liver copper increases, urinary free copper increases. Okay, next. Okay, read this MCQ. Read this MCQ and give me the correct answer. Yes. MCQ number 11. A 60-year-old male, known case of ischemic heart disease. So heart attack history is there, diabetes, hypertension. Patient came with severe dyspnea, breathing difficulty, history of fever, cough present. PaO2 oxygen is very very less. Carbon dioxide it is also decreased. So oxygen is not able to enter and CO2 is going out. So alveoli they are having some fluid. Alveoli it is having some fluid. Oxygen is not able to enter, but CO2 it is highly diffusible gas. So carbon dioxide it is traveling from the blood to fluid in the alveoli and then outside. So there is fluid in the alveoli. Okay. Age of the patient 60 year. Age of the patient 60 year. pH 7.5, alkalosis. CO2 is low, that's why pH is increased. So it is respiratory alkalosis. So I will suspect mainly respiratory cause. Chest X-ray and ECG both are attached. What is the most probable diagnosis? Chest X-ray and ECG both are attached. So chest X-ray, if you see carefully, see this is heart shadow. This is our heart. Then see the upper part of chest, it is normal. Upper part of lungs, it is normal. But if you see the lower part, this is haziness. This is haziness. Okay. So what is your diagnosis? They have asked. See the ECG. ECG is showing a lead 1, 2, 3. Rhythm is normal. P waves present. Tachycardia is there. There is no ST elevation, no reciprocal changes. So it is not MI, it is not ischemic heart disease. Then it is not a cardiac failure, congestive cardiac failure. What will happen? In congestive cardiac failure, what will happen? There will be abnormal white shadows like bat wing appearance. Upper, middle, lower, all parts of lung will be involved in congestive cardiac failure. ECG will show some changes. Okay, and history of fever and cough it is suggestive of some infection. Okay, so we are going towards the lung etiology, not the heart etiology. uh, Dental bird polyclinic, you are saying LBB, left bundle branch block. What is the criteria of LBB? It should be left axis deviation. So first thing, there is no left axis deviation in LBB. QRS should be broad. It should be more than 3 small square. Okay, so it is not LBB. Then W pattern in V1 V2 or M pattern in V5 V6, it is LBB. So it is not a case of left bundle branch block. So now see the option type 2 respiratory failure. So your concept of respiratory failure, cardiac failure, it must be clear. So is it respiratory failure? Is it cardiac failure? It is not a cardiac failure. ECG is normal. Okay. If you want to see the CCF picture of X-ray, I will show you in few minutes. So it is not a case of CCF. Okay. Next, respiratory failure. Two types. Type 1 respiratory failure, type 2 respiratory failure. What is type 2 respiratory failure? If there is a paralysis of muscle, the respiratory muscles are paralyzed, patient is having myasthenia gravis, then muscles they are not able to contract. So patient is not able to take the breath, not able to exhale the breath. That is respiratory failure type 2. In type 1 respiratory failure, there is liquid in the alveoli. For example, pneumonia, ARDS, liquid is present in the alveoli, so oxygen is not able to enter in blood. But carbon dioxide from blood, it is highly diffusible gas, so it enter in the alveoli, H2O of the alveoli, then it will go out. So CO2 will decrease in blood. Oxygen is not able to enter in blood, so oxygen will also decrease in blood. So it is type 1 respiratory failure. Why it is not acute myocardial infarction? because there are no changes on ECG. Okay, no history of chest pain. So we will consider respiratory case having history of fever and cough. So I will suspect bilateral lower zone pneumonitis. It is early case of ARDS. Early case of ARDS. Okay, this is the X-ray of CCF. In CCF, see the pattern of haziness. Haziness, it is called as bat wing appearance. In CCF, bat wing appearance. Done. Next. What is your answer for this? MCQ number 12. A 24-year-old female present to emergency with severe shortness of breath, audible wheezing, and use of accessory muscles. She is speaking in short phrases. On auscultation, her lungs are nearly silent, no air entry. What is the next best step in management? What is the next best step in the management? Yes, X-ray. Will you advise for X-ray? Clinically, chest is silent, no air entry, shortness of breath, wheeze is there. Severe acute attack of asthma. It is the severe stage of asthma. Status asthmaticus. Okay. We will give nebulization with salbutamol. Okay, it will open the airways. So answer is administer nebulized salbutamol and oxygen. Oral antihistamines, they will take time for act. We will give, but they will take very time. So in emergency, we'll have to give nebulize. Then we have to give injection of hydrocortisone. Okay, and if required, we have to intubate and we have to give ventilator support to this patient. Okay, and any other drug we can use magnesium sulfate also. Next, very simple MCQ. A 65-year-old man presents with sudden onset dyspnea, chest pain, D dimer is significantly elevated. What is the most appropriate next step? They have asked about the next step. Will you start aspirin? Will aspirin work? Order CT pulmonary angiogram, reassure and discharge, repeat the dimer in 1 week. So very simple, see acute onset, breathing difficulty, chest pain patient, definitely you are not going to discharge, 100% not. You are not going to repeat the dimer. It is not the time to wait. It is the time of action. And what action should be taken? Yes, Prabha, you are correct. We will go for CT pulmonary angiogram to confirm our diagnosis of pulmonary thromboembolism. It is a case of pulmonary thromboembolism. If I want to give a drug, if they ask you which drug should be given first, it is heparin. The drug should be given in emergency, it is heparin. Okay, CT pulmonary angiogram, it will confirm your diagnosis. Okay, aspirin will not work. Aspirin will not work. It is not a heart attack. It is not the heart attack. It is the blockage of a vessel in lung. So we give heparin, or you can use tenecteplase, streptokinase, these drugs. Next, a patient with rheumatoid arthritis is started on methotrexate with supplement is routinely prescribed along with it. A simplest one. With methotrexate, which drug should be given? Akansha is asking when to give streptokinase. Now there are different indications in this pulmonary. If CT pulmonary, if it is giving you the 100% diagnosis of thromboembolism, you can give the drug. Okay, generally we prefer streptokinase to be given within 4 to 6 hours. It will work. Once there after symptom 4.5 hours are crossed, it is not going to work. So it should be given within 4.5 hours from the symptom. ओके, कभी कभी 6 घंटे तक भी दे सकते हैं. आपको लगता है काम करेगा, 6 घंटे क्लिनिकली देख के आप दे सकते हो 6 घंटे तक. ओके, हार्ट अटैक में भी आप 4 से 6 घंटे तक दे सकते हैं, लेकिन ईसीजी में चेंजेस आ गए, रिवर्ट हो गए, ईसीजी में तो नहीं देते हैं. Very good, excellent. Folic acid reason. What is the reason of folic acid? Simply remember, methotrexate decrease the absorption of folic acid. Methotrexate decrease the absorption of folic acid. So these patients, they suffer from the deficiency of folic acid. Deficiency of folic acid, it will cause pancytopenia, it can cause anemia, it can cause neurological clinical features. To avoid this complication, always give folic acid and methotrexate together. And remember, we advise methotrexate once in a week. We will advise methotrexate only once in a week. So suppose I am giving methotrexate on Monday, so it will block the absorption of folic acid. So if you give folic acid on Monday, this folic acid will not be absorbed on Monday, so it will be useless. So on remaining days, Tuesday to Sunday, I will ask the patient to take folic acid, and on Monday I will advise the patient to take methotrexate. Both are not giving simultaneously. Okay, next. These are two important points. Methotrexate, it is folate antagonist. It inhibits the dihydrofolate reductase. This enzyme is needed for converting folic acid into its active form. So this methotrexate, it also inhibits the conversion of folic acid to its active form. Next, all of the following are causes of giant A wave in GVP except. Again, focus on except. Again, focus on accept. So give me the correct answer. All of the following are causes of large, very large, giant A wave. So JVP are having A wave. What is the cause of A waves? Atrial contraction. Right atrial contraction. When right atrium contracts normally, then A wave will be produced. So what are the causes of giant A waves? When right atrium is contracting against very high pressure. So what, when the right atrium will contract against very high pressure, or when right atrial pressure will be increased, in front of the right atrium tricuspid wall is present. If there is tricuspid stenosis, there will be increase in the right atrial pressure, tricuspid stenosis, it will cause giant A waves. Then pulmonary stenosis, blood travels from right atrium to right ventricle. From right ventricle, it enters in the pulmonary wall. But if pulmonary wall is stenosed, right ventricular pressure will increase. So it will increase right atrial pressure. Right atrium has to contract against increased pressure of right ventricle. So pulmonary stenosis, it is also the cause of giant A waves. Pulmonary hypertension, pressure of pulmonary artery is increased, so right ventricle has to increase the pressure to push the blood in pulmonary artery. Right ventricular pressure will increase, so right atrial pressure will increase, A wave will increase. Aortic stenosis is not the cause. Correct. All of you are very good. Excellent. You are giving me the correct answer. So answer is aortic stenosis. It will increase the left ventricular pressure, left atrial pressure. It is not going to increase right atrial pressure. Okay. So aortic stenosis, it is not the cause. Done. So answer is aortic stenosis. Next. So thank you for your patience. We have discussed the most important points of medicine. I hope you understood this. If you have any doubt, you can message me on this my number. This is my WhatsApp number. So all the best, all the very best to your exam. Stay calm. ज़्यादा स्ट्रेस नहीं लेना है, टेंशन नहीं लेना है, बस आपको पढ़ाई करते रहना है. ओके, सो डोंट टेक स्ट्रेस, जस्ट ट्राई योर बेस्ट, गिव योर बेस्ट, यू कैन डू इट. साल भर आपने बहुत मेहनत की है, आप अच्छा करेंगे. ट्रस्ट योर सेल्फ और पूरा नींद लीजिए, अच्छा खाना खाइए, हेल्दी खाना खाइए. अभी आपको बीमार नहीं होना है, अभी हमारे पास टाइम नहीं है. ओके, सो पूरा नींद लेना है, दिमाग शांत रहना रखना है आपको, कोई एंजाइटी नहीं. पूरा मेहनत कीजिए और भगवान के ऊपर छोड़ दीजिए. ओके, सो ऑल द वेरी बेस्ट फॉर योर एग्जाम. So ECG lead change, please. What want you to ask Nikesh? Can you explain ECG lead change means what? क्या पूछना चाहते हो निकेश ECG lead change के बारे में? Yes, Nikesh. Okay. Arshia was asking in non-ST elevation which drug are given? If patient is having non-ST elevated MI, अगर है आपको किसी पेशेंट को है तो आप पहले क्या देंगे उसको? एस्पिरिन, लोडिंग डोज कहते हैं इसे, कंपलसरी इमरजेंसी में देना है एस्पिरिन 300 मिलीग्राम, क्लोपिडोग्रेल 300 मिलीग्राम, उसके बाद आप दोगे अटोरवास्टैटिन 80 मिलीग्राम, ये हो गया आपका लोडिंग डोज। ओके, इसके बाद अगर बहुत पेन हो रहा है तो आप मॉर्फिन दे सकते हो, लेकिन सब हॉस्पिटल्स में अवेलेबल नहीं होता है क्योंकि मॉर्फिन ड्रग इजीली अवेलेबल नहीं होता है। ओके, सो इट इज बेसिक। अभी नॉन एस्टिलिवेशन एमआई में आप इमरजेंसी में हेपेरिन भी दे सकते हैं, ये होगी इमरजेंसी ड्रग। लेकिन आपसे अगर पूछते हैं कि नॉन एस्टिलिवेटेड एमआई का ट्रीटमेंट ऑफ चॉइस, फर्स्ट लाइन ट्रीटमेंट क्या है, सबसे बेस्ट ट्रीटमेंट क्या है, तो हम करेंगे उनका एंजियोप्लास्टी। डायरेक्टली पेशेंट को लेना होता है इमरजेंसी एंजियोप्लास्टी के लिए। ओके, डायरेक्ट कैथ लैब में लेना चाहिए और एंजियोप्लास्टी करना चाहिए, इट इज द ट्रीटमेंट ऑफ चॉइस। लेकिन इतना जल्दी इंडिया में अवेलेबल नहीं होता है, तो हमारे पास पेशेंट आएगा तो इमरजेंसी में ये सब देंगे। ओके ओके, ईसीजी लीड्स प्लेसमेंट अगर हम बात करें, ओके, सो एंटीरियर वॉल, अगर देखो सामने से कौन से लीड्स होते हैं, यहाँ पे V2 V3 V4, ये एंटीरियर वॉल को देंगे। ओके, अगर हम दो लीड्स होते हैं, चेस्ट लीड्स और लिम लीड्स, just a minute, if possible my ECG lecture, ECG basics, so just see. ओके, सो ऐसा प्लेसमेंट होता है V1 V2 V4 V5 V6। ओके, सो इसमें जो हमारा प्लेसमेंट है ये यहाँ से शुरू होगा, 1 यहाँ पे, 2 3 4 5 6 यहाँ पे। तो ये जो लीड्स है V1 to V6, इनको बोलते हैं चेस्ट लीड्स। ये हार्ट को सामने से देख रहे, ये सारे हार्ट को सामने से देख रहे, इनको बोलते हैं चेस्ट लीड्स। उसके बाद होते हैं लिम लीड्स। अगर हम लिम लीड्स की बात करें तो ये जो होता है ऑरेंज, ब्लैक, ग्रीन एंड येलो, ये प्लेसमेंट होता है 1 2 3 AVR AVL AVF। अभी हम अगर लीड 1 की बात करें तो 1 हमारा पेश 1 यहां से देखता है, लीड 1 and AVL they are watching the heart from the left side, 2 3 AVF they are watching the heart from downward। तो जो 1 and AVL है वो लैटरल वॉल, जो लैटरल वॉल में जो चेंजेस होंगे वो 1 एंड AVL दिखाएगा। इंफीरियर वॉल में जो चेंजेस होंगे वो इंफीरियर लीड्स 2 3 AVF इंफीरियर लीड्स। AVR राइट से देखता है, तो पोस्टीरियर वॉल में चेंजेस जो होंगे वो AVR में आएगा। ओके ओके, so all the best for your exam. If you are having any doubts you can ask me, you can message me on my number just I have shared with you, or you can follow me and ask me your doubts on Instagram also. So okay, so all the best, thank you very much. So I am stopping the lecture now.